We'll be able to grab one of these chairs and pull it back and it's not being used.
I'm sure.
They said there were 6 chairs on it.
Yeah, there's,
It doesn't look like there's 6.
these are 2 more, so you're.
Do you want to each share this back?
I do see that this is scheduled. They're extremely contentious. The regular time to begin our meeting is 12:30. You will notice on the agenda for September 30th, it says 12 o'clock. That is an error, and we will begin our meeting now at our regular time at 12:30. So I would like to call to order the September 30th meeting of the Panhandle Health District number 1 in the state of Idaho. The other correction in your meeting agenda would be down at item number 5, and we will not be having an action item. We will have a report about the Bonners Ferry building remodel, but there will be no action. There's no action needed on this issue, but you will hear a report on this. All right. At this time, I would like to invite you to stand as we pledge allegiance to the flag. I pledge allegiance to the flag
of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
Thank you. You may be seated. The next item on our agenda is to call for public comment, and you will see the instructions and the guidelines for the public comment. You will be given 3 minutes, and there are certain limitations. You are not allowed to speak about personalities, only issues, and we don't respond to public comment at this time. So I will open. May I see raise a hand if anyone wants to make. All right, I'll call on you first. State your name, and you have 3 minutes.
My name is Fiscal. I recognize some of you have some coordinators. I wanted to, I'm hoping you guys will explain the C4 National Electronic Disease Surveillance System. And I'm looking forward to hearing the director's report on HB 316. I'm not sure why we didn't have this meeting downstairs to accommodate more of the needs of the public. That was my main thing, is you guys need to rethink where you have these meetings. I know you have some where there's crickets and there's like 2 of us and we're all watching paint dry, but you're having more people and it's upsetting people that you didn't pull it in your normal venue downstairs or being accommodated. Rethink that in the future because you got grumpy people outside. That's all.
Thank you. Next, I saw this hand. State your name.
Hi,
And you have 3 minutes.
thank you. I'm Sandy White, and I just wanted to first say welcome to Ms. Jameson. I wasn't here at the last meeting, but we're really happy that you're here. Congratulations to Ms. Stephanie for the new directorship. As a concerned citizen, I like to keep up on your meetings. Unfortunately, I wasn't able to attend your last meeting. I see from the minutes that I saw online that this meeting was changed from the 23rd to the 30th. But there's nothing on your webpage that indicates the date change. So the calendar still says the 23rd, and these minutes were not available until just a day or 2 ago. So I just recommend that you're more public and more careful to notice the date of the meetings in the future. And I agree with my friend here that the meeting should be in a larger room. We're used to the larger room downstairs. And a lot of concerned citizens have come and want to be a part of the process and see what's going on and be involved, and they have concerns too. And and we were not allowed into this room until just now. I know we wanted to start promptly on time, but we were not allowed in until the very last minute. I was here a half hour just to get my place in line. So, thank you very much.
I see your hand. I recognize you. State your name.
Yes, hi, my name is Josephine Mongan. I'm a resident here in Coeur d'Alene, and these two ladies pretty much covered it. I don't understand how you have a meeting with public comment, though you don't have the meeting in a room that can allow public comment. That makes zero sense, and we've been seeing that type of thing around the community here, where they're using capacity numbers as a problem of us citizens being able to speak out on topics that are important to us. So to have a venue that you can only fit 6 people for public comment is ridiculous, and it seems very strategic to me. That's not okay. We have a right to comment. We have a right to come here, and it's you guys' job to provide a venue that people can do that. It's ridiculous that there's people peeking through the windows that want to talk. We're supposed to filter in 6 people. How long's public comment gonna take? No, you can't answer that, but they're gonna miss out on their opportunity to say what they wanna say because you guys chose a venue that only can allow 6 chairs. I go to all these meetings. I go to the commissioners, I go to the school board. It's the first time I've been here. And to have to deal with this at yet another entity in this community, I'm a native here, I've lived here my entire life. I've never seen this conducted like this. And my patience is shot with it. I'm about done. And everybody
Time
else
out.
out there and everybody else in this community is done with it. So please, respectfully, start respecting the citizens that want to talk and get venues that we are able to talk, please.
If I leave, could someone else come in and give more public comment?
Absolutely.
Okay,
Well, absolutely more people can come in to determine.
if I let them in, can they get public
Can they get
comment?
public comments still open?
You're welcome to leave anytime.
If I give up my seat and someone wants to give public comment, are they still allowed?
Is this room at capacity?
I'm sorry, ma'am, you are out of order, and you may leave at any time.
That's a no.
I said you may leave at any time.
I will give up my seat if another person is able to come in and give public comment.
I said you may leave at any time.
So that's, I'll leave it like someone.
Okay.
I'm not a jerk.
Is there anyone else now with a hand raised for public comment? All right, I recognize this hand. State your name, please, and you have 3 minutes.
Katie Nightingale.
Your time is Your time is running. You have, your time is running, ma'am.
Did she have my time?
I recognize you. You have the floor.
I don't agree with mask mandates or vaccine mandates, and I want to state my opinion on that.
Does that conclude your comment?
I also don't feel like this room should have been used for this meeting. It doesn't. There's a lot of people that have things to say. I'm going to let one of them come in and have something to say.
Is there, I recognize this hand. You have the floor. Please state your name and you have 3 minutes.
Okay. It's up to you. So my name is Randy Neal. I have a bachelor's degree in sociology and psychology. I graduated from honors from Lewis and Clark State College. And one of the things I'm concerned about is the interests of this board in mandating masks as, I'm gonna cite a peer-reviewed psychological study from JAMA. It's very highly credible about the psychological damages that incur when a person is forced to wear masks for long periods of time. This board is obviously concerned with the health of the community, and I would also hope that that encompasses suicide rates as well, and mental health. And based on my own knowledge, training, and experience in this, there's a lot of various needs. I've known individuals with autism, for example, who cannot handle the stimulus of having a mask on their face. A one-size-fits-all approach to this does not work, and it's causing psychological damage to our children and to adults. I had a friend that he felt so repressed and depressed about after being locked down and forced to cover his face for
1 minute.
at work. Committed suicide. His name is David Sauce. He's a member of this community. I hope that this board cares about his life and will honor the loss to this community that individual is no longer going to be contributing because of these things.
30 seconds.
I appreciate your time and your consideration in this matter.
Thank you.
Mr. Mayor, can you sign on that one? Put it for the 40-minute line?
All right, do I see any other hand to wish to speak? I recognize this hand. Please state your name, and you have 3 minutes.
Okay, my name is Deborah Denny, and I'm just a grandma here. What I've seen over the last 22, 23 months with all over the country wearing a mask, all over the world wearing a mask, doesn't seem to be helping. The only thing I see that it's doing is causing children especially anxiety, depression, suicide. It's not normal. You can go into the hospital, let the doctors wear their masks, let the nurses wear their masks, but for kids to wear a communist mask, it's not normal. And we're gonna lose our kids. We're not gonna have a very healthy next generation of our school kids if we keep masking them up, where all you see is their beady little eyes and everybody's going to and fro, scared to death. You look at India. What happened to India? It's done. Give them something that works, and we know that what works. And Norway, they just decided just to get rid of all the masks and the vaccine, everything. I just really feel for my grandkids and my kids. I have one of my sons a fireman, one's a ER nurse here at the hospital. They're not going to get vaccinated because they know it's not a vaccine. So I don't know if we're talking mass vaccines here or whatever, but they're not doing that. They're going to walk. So it just goes back to the mask doesn't work. My daughter, my son, everybody that's in the healthcare field, as you guys probably know, they've all had COVID. They survived. Granted, some people don't, but most people survive. It's a 99.6% chance of your survival. But 1 minute. So anyway, just basically for the next generation, our kids in school, or just anybody out in the public, I think God did not make us with a covering that we do not use our nose and our mouth. And it does not protect you from any kind of virus. That's just my comment. And I'm firm. And all of our family members are in healthcare and they're totally on our side, so it doesn't work. Get rid of it. It's causing a lot of problems with our kids, right? Sad, very sad. I'll let someone else talk.
Carol, can you make sure, or can you request that post that speaks on them so I can have a respond to them?
Yes, ma'am.
I think it could be this.
Is there anyone here who hasn't signed that? Feel free to do so. Okay. Is there any, do I see any other hand raised for an opportunity to speak?
Oh, I think we may have one.
All right,
Yes, do you want
this-
to come in and comment? Sure. You get to be in the hot seat.
Okay,
Yeah.
and please sign the clipboard. And state your name, but I have not seen your hand raised, so I'm getting ahead of myself. Do you wish to speak? We recognize hands that are raised.
Oh, okay.
Thank you. All right, state your name, and you have the floor for 3 minutes.
Okay, thank you. Tricia Bolton.
Okay.
So I'm coming to represent my family and the rest of the people of Idaho. There is absolutely no science behind the masks. Unless you have N97. And I'm just vehemently opposed to you guys forcing children to wear them. Or frankly, any business to wear them. It's not constitutional. And I don't see how the vaccine is constitutional. We, the people, you guys are supposed to be our representatives. And I don't really feel like the representatives. And I don't understand, why we couldn't be in the bigger room downstairs so that more than 6 of us could actually come in and talk. Present. So obviously we've done a poor job with our commissioners because we all learned the hard way last year that we don't get to elect you guys, you're elected by the commissioners. But I guess there's a lot of us that are, who've had it, we don't want your guys' masks or vaccines or whatever else it is, your agenda, it's not our agenda. So I just ask that you really also look into the science and show us where the vaccine is effective or the mask. Because that pump mask, it's like putting a mosquito in front of a chain link fence, it just goes through them. There's zinc, there's ivermectin, there's so many things that will help you get better if you get sick. It's not, this is just like the flu, it's not in pandemic. The death rates in Idaho are not different the last 2 years. The deaths by heart attack and blood clots are way up, but they're not recovered. This is just an agenda to control us.
1 minute.
That's basically all. Thank you.
Do I see another hand who wishes to respond, public comment? I recognize this hand. You can come up and sit in this chair. There's no difference between that chair and this chair other than we can see you better. And you have signed the sign? Okay. Oh, excuse me. I need you to state your name, please.
Marilyn Keel.
Okay, and for the record. All right, you have the floor for 3 minutes.
Okay, I will talk about it. Okay, I'm a grandma and, I have 4 kids, 4 grandkids, and I have a dog. He's like 9 years old, and he's such a sweetheart, but last year, when he had to wear a mask all year long, it made him an introvert, and at the end of school, when summer vacation started, he would not take his mask off. His parents literally had to get mad at him because he felt so comfortable with that mask on that that became like his identity. And psychologically, they had a real hard time with him for a while to not be comfortable without the mask on. And that's not right for a 9-year-old boy to have to get so comfortable with something that is covering your face. And think that that is how he can relate to the world, is by this mask. And I've gone to a lot of different, of course, stores that are selling the mask, and I have on my Facebook, and I already sent this picture to the Board of Trustees. And I don't know if anybody in here is aware, I hope you are, can I read something that's on all boxes, all or any boxes of masks? When you want to buy a box of masks, can I read that to you? Is that acceptable?
You have 3 minutes.
Okay. It says, these masks are not personal protective equipment and are not intended as replacements or substitutes for personal protective equipment. These products are not intended for medical use or to prevent any disease or illness. Each mask is intended for single use only. So the manufacturers that are making these, they know they're not working. I'm sorry, they're not working. And so that's just, it's just not a way, for kids to be in school 8 hours a day. I believe it's a matter of choice. I understand how I'm respectful of people who want to wear them, but certainly the forcing and mandating of these masks is absolutely not constitutional. And so,
30 seconds.
so I guess that's all. Thank you. for letting me have some time.
Thank you. All right, is there any other hand? I see that hand.
Yes,
Yes.
speak.
We'll see you better if you will come up here. Have you signed the clipboard for us?
Will.
Okay, thank you. Okay, now I ask that you would state your name and then you have the floor for 3 minutes.
Okay, my name is Mark Price. I live here in Coeur d'Alene. I've been here for 18 years. Didn't know about this meeting until last night. I guess we're talking about masks. So if you guys remember when this pandemic first started, Fauci comes out, he's all over the board. You need a mask, you don't need a mask, you need goggles. So I was one of those parents that got scared. I put a goggles, masks on my children, tons of hand wash, I've done everything right. Then I started studying. I started looking at the size of the mesh versus the size of the virus. Now, if anybody looks into this, it's pretty easy to see. It's like putting up a chain link fence to keep a mosquito out. That's the science. So now if you got Fauci holding, we'll put 3 masks on. What's going to be next? Full face respirators? They don't work. It's that simple. And more important than that, this argument, by trying to take parents and citizens' free choices away, you're going to destroy this community. Because you got pushed back last year, it's going to be 10 times as bad this year. People are tired. They're tired of being told what to do. We're tired of having to pull our children out of school for their safety. There's tons of study out here. Have you seen the video of the little girl that happened to have strep throat? She was forced to wear a mask. It ate half her nose off. That's just one story. So when you guys make a recommendation, this affects thousands and thousands of parents, children, and hardworking people that work in this community. So I just want you to take that into consideration before you start pushing the mask mandates, because there's going to be a lot more pushback this year than there was last year. And I know I'm going to be on the front line pushing. But that's all I have to say. Thank you.
Yes. All right. Anyone else with a raised hand? I recognize that hand. You can speak from there or there, wherever. Have you signed the clipboard for us?
My name is Tommy Densich. I live here in Coeur d'Alene. just a few
Okay,
blocks away.
I need a yes or no. Have you signed the clipboard?
I have not. Yeah, I live about 3 blocks away, and all this talk about pandemics and masks and social distancing and all that, that's just a smokescreen for what's really going on here is a worldwide psychological operation stemming from the UN Agenda 2030. And right here in Coeur d'Alene, we're under the Coeur d'Alene 2030. That's what it is, to control mankind in general. That's what this whole thing is, and that's the origin of all the problems. And that's what's happening. And the Panhandle Patriots are not putting up with it. We know what the story is. I read all the information, been studying this for 30 years, and we are not going to put up with this. This is a place for freedom. I came from California up here to be free. And that's what we're going to do. We're going to keep this place free. And you guys just be on those. Go ahead.
Do I see any other hands who wish to speak? I see a hand over here. Do you wish to speak?
Yes, I would.
All right. You can speak from there, or we can see you better from this chair. So come on up.
Wherever, yes. Ready to sign?
Yes, please sign.
Sorry, I'm a little unprepared for that. Last moment.
Okay, we need you to state your
Oh,
name.
yes. Sorry, I'm Alexis Thornton. I'm from Rafton, Idaho. And I have a 7-year-old daughter who is not able to wear masks. My daughter suffers from migraine seizures from a vaccine injury. We are not able to get a medical exemption. She's had to experience so much trauma and judgment and segregation because of her condition, because she can't wear a mask, and no one will let us in. On top of that, I'd just like to bring something up. As a person of color, I already am a minority in North Idaho. There's not many African Americans here. And what we're doing here and what the school system is doing and what the county is doing reminds me of segregation. It's exactly the same thing. And I feel absolutely targeted here, and I do not feel safe. And I moved here to feel safe and to be part of this community. And that's not how I feel anymore. And it's really, really frustrating to see this happening here. Because I don't think people are taking that into consideration as well. I'd like to start getting more people of color in North Idaho involved in these meetings, because I don't see many migrants here. I'm usually the only one. So this is really uncomfortable for me at the same time, but I also think it's really important that I start speaking out. That's all.
Do I see another hand? I see that hand.
I already signed up.
You've already signed. Thank you. All right, please state your name.
My name is Noah Nichols.
Okay, and you have the floor for 3 minutes.
I would just like to state that even though I might seem young in any case, I have been, and in many cases, so originally I moved here from Texas 3 months ago, and originally before that, I was a part of I can't exactly state the name for it. They were called the Civil Air Patrol, and in that, they were pushing the entirety of the mask mandate. Now, I followed this, and several times it did affect me psychologically, and that's what I would sort of like to state, that it just, sometimes I would feel depressed, sometimes I would just, sort of trudge on with it, and I would do this not only to not, yeah, that, the bonded, that. And also to fit in, and it's very, I would assume, mostly coming up here, I don't want to ask you, but it's just, when you see everyone else doing it, it makes you want to blend with them, it makes you want to follow what they're doing. And that is a very effective psychological tool in corrupting people and making them just in general control. So,
Another hand? Second call for anyone else wishing to speak? All right. We're at our third and final call for anyone wishing to make public comment at this time. Seeing no other hand, we are going to, at this time, close the public comment. And the time we are closing the public comment, Jill, is, I'm sorry?
1:02.
Thank you. All right, public comment is now closed. And of course, anyone here, you're welcome to stay or you're welcome to leave. It's your choice. All right. We did not have a space to officially welcome our latest, newest board member, Dr. Jessica Jameson. And so I want to take a moment to say how delighted we are. And anyone else, board member here, would like to give a word of welcome to Dr. Jameson. This is your chance right now.
Mr. Chairman, if I could, I just want to say thank you for coming and participating. We invite your active participation and your comments as we discuss the items on the agenda. So good to have you here.
Right. And give you a moment if you want to say anything to the board.
Thank you for having me. It's quite an honor. I think that the pandemic, if nothing else, has shed a lot of light on the importance of public health and the importance of the health board in various aspects. So I've got a background in the military. I was a flight surgeon for quite a few years, and there's a lot of public health involved in the flight surgeon role and responsibilities. So I'm quite familiar with the things that the board does outside of a lot of the things that have been in the spotlight recently, in addition. And so it's just an honor to serve, to give back to the community, and I look forward to it. Thank you very much.
You might want to bring that mic over a little bit closer to you. We need to be within about 20 inches or so for it to.
Sorry, Dr. McLanders, you probably didn't hear me, huh? Good, perfect, now we can hear you. Thank you for having me, I look forward to being here.
Okay, Dr. McLanders, you may be muted. We are not.
Okay.
Okay.
Still okay.
Okay, Robert, what's the answer? Okay.
Shows he's muted now. Now he's unmuted.
Yeah, because we hear like, that's my.
Now we got you.
Can you hear me now?
Yes, loud and clear. All right, we will carry on with our agenda. Next item on our agenda is the consent agenda. There are three main items: the minutes from July 22nd. And if you have any comments on those minutes, we can hear that now. There's also the division reports, and I trust you've had a chance to read through the division reports. And then we have a list of the contracts that have been signed by our director. Anything you want to pull from the consent agenda, we will hear you now.
Yeah, Mr. Chairman.
Yes.
I'm curious about items 1 through 4, and maybe we could have a little more explanation as to what those are.
All right. So we will pull contracts 1 through 4, Dr. Meek.
I through, no, I guess,
What is it? The little Roman numeral.
All right.
1 through 4.
understand what you're trying to say now. Okay.
All right. We will pull those and go to them later. Anything else you wish pulled from the consent agenda? If not, I will entertain a motion to receive and approve the consent agenda with the exception of the first 4 contracts. Is there a motion to that effect?
So moved, Mr. Chairman.
We have a motion. Is there a second?
I'd second it.
All right, it's been moved and seconded. Any other discussion on this motion before we vote? If not, we are moving to approve the consent agenda minus the 4 contracts on your list. All in favor indicate by saying aye.
Aye.
And opposed, no. All right, we have approved the consent agenda with the exception of the 4. There's the Kootenai School District and the immunization site visits and immunization and the National Electronic Disease Surveillance System. All right. Mr. Director, are you prepared to make any comment on those 4 items?
Yes, Mr. Chairman, thank you for the opportunity to describe these contracts. So the first, item 1, is our Kootenai School Nursing Contract, where we provide a school nurse to that particular school district. And there's multiple services that are associated with that, but they're very typical school nursing responsibilities for that school. Item number 2 is our immunization, one of our 2 immunization contracts. And in this case, the state provides funding for immunizations, and we have a number of providers within our community that are a part of this agreement, and it's our responsibility to audit the work that they're doing to make sure that they're following state guidelines associated with administering those immunizations that are provided by the state. Item number 3, again, a second immunization contract. And this allows funds for the health districts to promote immunizations within the community and to set up other off-site vaccination clinics, which we do throughout the 5 counties here in Idaho. And the 4th contract, our surveillance program, is, as you know, there's over 70 reportable diseases here in the state of Idaho. All of those reportable diseases are to be reported to the health districts. So this provides the system by which providers can electronically send those lab reports to the health district. And then it's the responsibility of the health district to monitor those reportable diseases, look for outbreaks, and do disease investigations associated with them.
Any other questions, Dr. Banks?
No, thanks for the clarification. I appreciate it.
All right.
Mr. Chairman, if we could discuss briefly item number 1, which is the Kootenai School District funding for their immunization programs, I guess.
Absolutely.
My question, Don, for those 18 and younger, or less than 18, so they're still juveniles, do you know what the COVID-19, what the record is for those youth being infected with COVID-19? Any idea on the numbers?
So, Mr. Chairman, if I'm understanding the question, what percentage of the under 18 have been infected with COVID-19?
Well, the numbers, yes, the percentage.
Yeah. I don't know the percentage, but I can tell you that in the 5 northern counties of Idaho, I'm pretty close in my estimate that there's been 3,500 cases of COVID-19 for those that are under the age of 18, and we have had 29 of those that have been hospitalized. None of those that we know of have been in ICU. However, Kootenai Health does not have a pediatric ICU, so if that were needed, they would be transported to Spokane for that service.
Thank you. And a follow-up question would be, for the youth that are infected cases, what is the seriousness of the COVID for the youth? In other words, in my opinion and my studies, it doesn't affect the youth nearly like it does those in the older demographics. And I don't see the utility of vaccinating all those young people when studies have also indicated that the natural immunity after you get COVID is much higher than the quote unquote vaccinations, which are gene therapy. They are not true vaccinations because you can still catch the virus and you can still transmit the virus. In fact, studies have shown that you're getting worse infections of the virus after having the vaccine than not having. So that's my question is, why are we, as the health district, pushing vaccination of children, those under 18? What data are we using to do that? Would be the question.
Yeah, I appreciate the question, and Mr. Chairman, I would answer that in a couple of ways. First of all, your question, I believe, is, what is the lethal nature to those under the age of 18 who get COVID-19?
They don't have comorbidities, because I understand that there are some youth that do have the heart issues, the lung issues, but I also understand that those getting vaccinated, the youth and younger people, are having huge issues with blood clotting and heart and strokes caused by the vaccination itself at a much higher lethality than getting COVID-19.
Well, what I can do is to just give you data that we know have here in the 5 northern counties of Idaho. And one of those pieces of information is how many cases that we've had. And I mentioned that earlier. It's over 3,500 cases that we've had thus far. Over the last 2 months, the rise in cases has skyrocketed for that age group. And so
cases doesn't equal mortality by any means.
Yes, sir. And I will continue with that answer. Is that of the 35 to 4,000 we've had thus far, as I mentioned, we've had 29 that have required some kind of hospitalization. And we currently have had no deaths in that age group since the beginning of the pandemic. So that would give you some idea of where we are thus far. What we don't know is the true lethal nature of the Delta variant. that we don't know particularly. There is some data that is certainly pointing toward the lethal nature, at least more than the alpha variant that was before. And, as school has just rolled out, more information will be coming on board to determine if it is more lethal or not. So I think we're interested in seeing what that data. Your other question regarding some of the side effects associated with getting the vaccine. We have little or no indications of any of the outcomes that you have heard, and I have heard some of those as well, in North Idaho happening with that age group. But the caveat that I will provide is that there are no really good longitudinal studies associated with some of this, so time will tell. But there is a lot of clarity on the value of being vaccinated to prevent the disease and prevent death. And that information is pretty strong, which we believe in. Your question about, or comment about Panhandle Health District pushing the vaccine, yes, we have several clinics throughout the 5 northern counties, including one in each one of our 5 offices, where we provide opportunity for people to come to get vaccinated. We have no mandates in order. We are simply inviting people, if they wish, to come and get vaccinated. We do an excellent job through our public information to do our very best in providing information which will allow them to choose whether or not they wish to be vaccinated. And that's a very strong position that we have.
Yeah, and I appreciate allowing people the opportunity, that it should be their decision. And we've heard comments during public comment today about the mask mandate, which I objected to, and about, mandating vaccines. We're not even considering that, but I know how rumors start and what that means. But it should be choice, and people should have the opportunity to choose. And in my opinion, the COVID-19 variant D, variant I, variant whichever, and viruses do adjust and they do adapt when we come up with a vaccine to try to get around that, to try to defeat that. That's always happened with any virus that we've had in the past. And we adapt and we go on. So thank you.
All right, let me remind you that this is a discussion among board members, and so shall we hear from Dr. McLandris, and then I'll recognize Dr. Banks. All right, Dr. McLandris, you have the floor.
Can you hear me?
Yes, sir.
Great. Just briefly, I support everything. The statistics and information Don Duffy provided is very much in line with the research, not only nationally, but internationally. I would add that there is no supportable evidence that a pediatric patient who has been vaccinated has a worse infection from COVID if they do get that infection. I wanted to make sure that was clear. The stats still are that about 2% of kids are going to become ill upon acquiring the infection. There are 3 kids in the Spokane PICU, the pediatric intensive care. There are 3 kids in Spokane who now are in intensive care. The numbers in the pediatric children's hospital, I don't have them right in front of me, but there are many kids in our Spokane Children's Hospital now who are sick enough to be hospitalized. Certainly in Seattle, which is the catchment center for the Pacific Northwest, their pediatric ICU is full of kids who are very ill, who are on ventilators, requiring high flow oxygen. So admittedly, this is lower morbidity for the pediatric population, Glenn, as you point out, but there are still kids who are getting very ill from this illness, and there is very strong evidence that the side effects of the immunization are very low. That would be my added comments, Mr. Chair. Thanks.
Thank you. Comment from any other board
Mr.
member?
Chairman, if I could just ask a follow-up question, Dr. McClanders. Do we know what the thrombosis rate is among children receiving the vaccine? Have you seen any documentation on that? Because I understand that the threat from the vaccine is higher than the threat from getting actual COVID-19, that there is pediotrombosis. Is that correct?
It's not correct that there is a higher risk to the child who has, as a side effect of the vaccine from the illness. The most significant incidence, the side effect is in the adolescent age 12 through actually age 24, approximately 6 to 8 per million doses of a inflammatory condition of the heart called myocarditis, and an incidence of approximately 1 to 2 per million in which that could cause potential illness. So I'm trying to clarify, it is not more risky to get the vaccine than it is to get the infection.
Okay, so it's myocarditis, not thrombosis. Thank you.
Correct. Yeah, correct.
And
The thrombosis is more of an adult population. Yes.
All right, calling on Dr. Banks. You have the floor.
Well, thank you, Mr. Chairman. Yeah, I just want to remind everyone that a positive case does not indicate disease. A positive case means a positive test in the RT-PCR test. And the RT-PCR test is not an approved test. In fact, it has been decertified by the FDA because, according to the FDA, the test cannot differentiate between influenza and COVID. So I maintain that, in fact, every case of COVID has in fact been influenza, and there is no evidence to indicate that there's any difference because the PCR test is the whole basis of this pandemic. And the pandemic now, based on the latest action by the FDA to decertify the PCR test as being unreliable, giving false positives and not being able to tell the difference from one respiratory disease to another, is pretty compelling. And further, as regards vaccine injury, the evidence is piling up is considerable. And the numbers I've seen is that you have if you're a child, you have 31 times greater incidence of suffering an adverse event from that versus suffering an adverse event from whatever this is, influenza or whatever the heck it turns out to be. So we are, promoting immunization, and that's not even the right term because it's an injection with something that's never been used before, and it's not approved either. None of these so-called vaccines for COVID are in fact approved. They're under emergency use authorization because supposedly there is no other treatment available. In fact, there really is other treatment available. There's ivermectin, there's hydroxychloroquine, there are options. So as far as I'm concerned, the EUA is called into question. But certainly these so-called vaccines are not vaccines. They're a genetic engineering experiment, something I know a fair amount about. And to call them a vaccine or to promote them, especially in schools for children, I think is irresponsible and in fact criminal. That's just my opinion.
Okay, any other comment? Dr. Jameson, do you wish to enter this arena with any comment? You may or you may not, it's your choice.
Sure, I'll enter. I think there's a lot of valid points that have been said sort of on both sides of this argument, but I think that what the public is really concerned about in many ways is the mandating of these things, right? And so I think that as the public health district, to offer a vaccination that there are many people feel is a wonderful option and feel is the saving grace to end COVID, it is a great thing to offer, right? But I think the question for me always comes in when we try to mandate these things. I think it's a slippery slope. And I think that's really what a lot of what we heard today is about whether or not mandating these sort of things is an issue. And as Don pointed out, the health department is not and has no intention of considering mandating these things. But what we are here to do is to offer this service to the public. And the public involves people who really want to get this for their child. And I think that that's a completely reasonable thing for them to be able to make the choice to do for their child. The concern I have is when someone tells me what to do for my child in that setting. And so I think circle back to Mr. Duffy's point, which is that the health department is not asserting that we should mandate this for 12-year-olds.
Okay. Any other comment from, yes, Don? Pardon?
I don't need.
Oh, okay. Don, do you have anything else you want to add to this discussion?
Yeah, thank you, Mr. Chairman. The contracts under review that you're considering to approve, the 2 immunization contracts, do not relate to COVID-19. There are other immunizations. These are not associated with COVID, the administration of COVID-19.
Thank you for the clarification.
Okay. We're at the point where we have 4 contracts that you either need to approve or disapprove. Now, at this point, our director has signed these. And it's for us to be informed about them. And if you can choose to approve, or you can approve to disapprove any one or none. It's your call. But we do need to take action on items 1, 2, 3, and 4 of these contracts. What is your pleasure? And
Mr. Chairman?
Yes, Dr. McLanders.
Mr. Chairman, I would make a motion to approve all 4 contracts.
All right, is there a second to the motion?
I'll second.
Been moved and seconded. Now, we've had quite a thorough discussion. I don't know whether we need more discussion on these. And this is a case, of course, where the majority rules, and we have all 7 board members here today. So I will call, maybe because we have some here on Zoom, that I need to call these one at a time. We are voting on a motion to approve these 4 contracts within the framework of one motion. So, Commissioner Mike, what is your vote?
Yes.
All right, Dr. McLanders?
Yes.
All right, Dr. McLanders, I hear your vote.
My vote is yes.
All right.
Yes.
All right. Dr. Banks.
Well, thanks for the clarification, everyone. I vote yes.
All right. Glenn?
And I would overall vote yes, with the reservation about number 1, the Kootenai School District. But I'll vote yes on approving contracts.
All right. Dr. Jameson?
Yes.
All right, and the 4 final contracts. They are approved by a unanimous vote, Madam Secretary. This takes care of the consent agenda. We will move on now to the Bonners Ferry building remodel. And as I reminded you a moment ago, that this requires no action. This is simply a report. Progress, yes. And we'll hear from Joe on that. We've already had some preliminary information on this, so this is simply an update. And one of the things I'm wanting to hear about, as you board members may or may not remember, Bonners Ferry facility has been there quite a while, one of our older facilities, but it happens to be the only facility that has constructed in such a way that the meeting room in that building can be used while the rest of the facility is under lock and key. We don't have that privilege in any other facility. So, Joe, as soon as you are ready, you have the floor.
Thank you, Mr. Chairman.
Sorry. First day of the new thing.
That's it. So as the chairman stated, I'm going to present on Bonners Ferry remodel. As you may recall, we had some difficulty with responsive bidders. And essentially we have one responsive bidder. He is very responsive and comes well recommended. So we're comfortable with the contractor that has been selected. We're finalizing the scope of work at this point, but I did want to present to you what we've come to at this point. The original construction of that building was in 1992. We have essentially not done anything other than repaired the roof. We've done some minor painting and replacing a few fixtures here and there, but there has been no renovation or upgrade in 29 years. We've provided some security enhancements to the building and building access enhancements. Previously, those were provided with the intent of the ability for us to integrate them once this remodel was done. Said another way, we coiled up longer spools of control wire in the wall so that when we move the wall, the wire, we don't need to bring the contractor back for security purposes. This is the entry lobby area looking at the counter where Angie sits and the entry door that clients would come in. One of the first things we're going to do is take and push that door back 12 feet. So that wall will disappear. You can't see it, but that wall is only about 3 feet long on this side. It'll stop there at where the existing wall to the lobby is. And then it'll continue back into a hallway that on the right side will be a wall. And on the left side will be 2 stations for reception that'll be behind a laminated glass counter. So the rounded counter is going to go away. There'll be a slot to slide things through and speak. And it'll be from the countertop up will be glass, and then it'll be framed into the structure.
Mr. Chairman, a question for Joe.
Yes.
Is that the only public entryway back into the
Yes, sir.
visiting rooms?
There's another door. If you were able to see it, it would be really right about where Kate is sitting. There's a door here.
Okay.
And that door will be, it's controlled by key card access, and it's not for
Public.
entry. Staff may go in and out. There may be some need for a staff member to come out there and greet the public in the public area, more from the environmental side.
Is there a staff exit other than these two?
Yes, so
doors?
there is. And it would be on the far end of the building as you were looking down this hallway and then to the corner. And so staff comes in from the back. And that's all card reader access as well, plus camera verification. So the hallway, again, that hallway door will move towards us in the image a little bit past where the actual photograph ends. There are 2 bathrooms there currently, and they'll remain. One will, well, I'll get into that. So basically the door that's that goes into the pill room will move 3 feet further inward as well. All of that will be behind the secure public access door. But there'll be a restroom for clients and patients to use that will be accessible without coming through the door. And then the flooring will change to a vinyl planking that looks like wood. Some of the stuff that you see in high commercial areas like restaurants or grocery stores, that type of planking.
A question, Mr. Chairman.
Yes.
So what's the repurpose of the restrooms? What's the thinking behind that?
Well, right now we would have to open the door if a client or a child needed to use the restroom. This will allow them to use the restroom and actually it be a public access restroom. So right now we have segregated men's and women's restrooms, but they're behind a door. So what made more sense was to move the door, allow the one restroom to be unisex, whoever needs to use the restroom, kind of like Starbucks. You go in and you use the restroom and then you lock the door. And then there'll be a patient restroom, which is currently the women's restroom. It'll be a unisex patient restroom on the inside that'll be blocked behind the door.
Thank you.
The lab area, so the wall that you see that's kind of a very light aqua color with a light switch on it and a freezer in front of it, that wall will extend out about another 5 feet. So it will enclose this space. And it will be, there'll be a pocket door in that wall. And then the refrigerator, which is further back in here, will move around next to the freezer. So they'll be there and circuitry will be provided so that there's ample draw for both circuits. And then the counter area, which you can't see, it's the counter there. That's going to shorten and be repurposed and resurfaced. But essentially, we're going to use the existing cabinetry where we can to not increase the expense. And again, vinyl planking throughout that area. The play area, which is very restricted in terms of view and really kind of an odd configuration. That wall where the IED and the fire extinguisher are will be removed. Clients will be able to observe and interact with their children if they wish to. All of the elevations there will come down to just be one floor, and it'll match the flooring of the rest of the lobby. That same vinyl planking. And the IED and the fire extinguisher will be moved to a different area within the lobby. The exam rooms, we'll put in new countertops. We'll put sound insulation between inside the walls, so between each room, there'll be more sound insulated so that one patient or client won't be hearing the affairs of another. We don't know that they necessarily can at this point, but we know that we have an opportunity to change that, and we're going to. And then it will go from the checkered board pattern there to the same vinyl planking. Other upgrades will include new paint and flooring throughout the facility, replacing lighting and countertops in the conference room, replacing window blinds and cabinet hardware, throughout the facility, updating and modernizing the cabinetry where it's appropriate. Some levels of cabinets will move up or down depending on what's needed by the staff. And then we're upgrading electrical and plumbing associated with the renovated spaces, but very minor renovations. We're not doing major retrofits on plumbing or electrical. Questions or comments? Yes, sir.
Who's the contractor?
The contractor is Larry Jenkins, and he's very familiar with government entities and contracting, and he does a lot of remodeling and refurbishing schools, county and city offices, and well recommended. So.
Another question, Mr. Chairman. There was an issue with the parking lot there and it just got repaved, is that right?
I believe it was restriped. It may have been resurfaced. With slurry, I believe. I don't believe it was paving, but.
Maybe Tim knows more.
Yeah, it wasn't repaved.
No, it was just slurry coated and striped. Yeah, sealed and striped, I guess would be.
Yes, and just, Tim, to your credit, or to someone's credit, the county commissioners were involved and helped us with that project.
It's right next to my store. So
Yes. We were able to share in that work. And we will continue to look to the county whenever we have joint projects like that to absolutely consult with you in advance, lighting or anything like that.
You know, Tim, we have found the county commissioners up there to be very, very kind and helpful to us. And you're going to fit right into that plan, aren't you?
Oh, yeah.
Mr. Chairman, I believe we have another.
Okay, Mr. Chairman. Joe, timeline for completion?
I'm reminded of something from my previous career where the commanding general told me, hope is not a plan, Joe. We haven't finalized that with him at this point. I want him to get the material specs to us and then I can give a better answer. But I'm hopeful that he'll be able to complete it within 2 months from the beginning of the project.
The other question was, will you be functional during the remodel?
I should have pointed that out. Thank you very much. The current plan is we will move the office facilities into the conference room. We will block off the door that goes into the lobby. That'll be locked off and construction will occur. The other thing we'll do is there's an office next to where the playroom is on the other side of that wall. We will cut a hole in and put a door into the conference room, which will allow for WIC counseling or exams to be conducted in that room and with adequate facility capability, a door that closes and all of that. We'll still be able to maintain operations. So essentially the conference room will be utilized by the staff. And we may have to have an EH person sit in the corner of the conference room quietly, or if it's not snowing, they may choose to sit outside. But
It's good,
yeah.
good to know that
Yeah.
you will have limited use still.
Absolutely. We probably, we likely will have to limit public use of the conference room during the construction phase because there's just no way to secure everything. But, and we understand that that is a facility that's used a good deal by the community, and we want to continue to do that and support that. And so we will minimize the time that it is not available. Jill, can you bring up the next presentation, please?
Chairman? Yes. So to answer the question of Mr. Bailey on the completion date, we did include in the RFP a request that is completed by June of 2022. And thank you.
Okay, you're going to carry right on, Joe?
Yes, sir.
With the new phone system. Go ahead.
Yes. I'm just waiting for the technology to catch up with me. That is not the new phone system. That's Dr. McClanders. That's not it. I'm pretty sure.
That's being shared. Just go to the bottom. There you go. Perfect.
Could we ask if Dr. McClanders or Commissioner Fitzgerald can see that?
The question is raised. Mike, Dr. McClanders, are you able to see this presentation?
Yep.
All right. So with regard to phone system, our current phone system is extremely limited. And by limited, I would paint a picture that just one step above string and cans is essentially what we have currently. It's not supported, which means there's no way to repair it or replace things under any kind of a warranty or contract. We would have to purchase new equipment. They do not manufacture anything that coincides with the existing equipment. So we'd have to physically replace it inside the server room with new equipment. Because of that and some other reasons, we chose to go with a cloud-based concept for the future. And we did a considerable amount of research one way and the other. What currently exists is we get a dial tone that's provided by our provider currently, which is Ziply. That will change to a company called Fatbeam because that contract was negotiated some months ago. And we received federal reimbursement for that as well under a grant through Health and Human Services. Right now, we have 4-digit dialing to all the phones in the district. In other words, I can dial a 4-digit number internally from my office and talk to Angie at her desk there. We only have desk phones. There's no interactivity with computers. Although the phones are plugged into a computer, they're not interactive with it. And we can transfer a call from one extension to another. But then if we get into complex transferring or conferencing if you have a cell phone, for instance, a client's calling on a cell phone and you want to transfer that in and then bring in another call, you'll drop the client off, not intentionally. And there's no integrated conference calling system. So we had an existing system that's broken. It cannot be fixed without buying new equipment. So all of these things were coming together at the same time. And the executive staff tasked IT with looking at what our new options were. This is what we spend yearly on telecom costs currently. $67,000, a little north of $67,000. We solicited 3 potential vendors that we knew had the capability to provide a variety of options, but at a minimum replace our existing capability and then have cloud-based enhanced capability. Those were Adnetics, Intectel, which is a part of Sangoma. That's the national brand, or actually the international brand, and then Ring Central. 2 of those have offices in this area, Adnetics in Post Falls, Intectel in Hayden, and then Ring Central is located in another state. Fully cloud-based, what does that mean? That means there's not a box anywhere in the building where the equipment is. The equipment exists at the vendor somewhere in another location. This one that we wound up with will actually be in Post Falls. DIDs for all phones in district. What does that mean? That means that the discrete phone number that you have on your business card that says, in my case, 208-415-5210 can be dialed. Our regional offices, that's not the case right now. You can't give them they have to call in to the main number and then be transferred to this to the discrete extension, if you will. This is everybody has their own extension and everybody has their own phone number. And there'll be some really beneficial part of that in a moment that I'll point out. 4-digit dialing. And by the way, the yellow is the enhanced capability that we don't have. So white shows just what we have right now. And actually, I apologize, we don't have soft phones now. So what a soft phone is essentially a headset that's connected to your computer. Our computers have touch panels on them for the most part, all the Surface Pros. So you have an option if you choose to, rather than have a conventional phone at your desk, you can just use your computer and make calls. So for instance, it would say Glenn Bailey on there. I would push it. I'd get a dial tone. I'd hear the ringing. You'd answer and we'd talk. And then I'd end the call. So we have that option. Phones, that, or both in some cases, if that was necessary. An integrated conference calling system, which is something that we don't have now. What does that mean? That means we can do conference calling at tiered levels. We can integrate them so that we can bring in all of our offices on one call and then conference in other entities. And it's somewhat unlimited in terms of the numbers of people that we could have call in. An enhanced auto attendant, which allows us to have a variety of tiered ringing, twice, 3 times. You get a message, you don't get a message, you get transferred and a message, you get transferred, you get a message, you get music, you get a person. All of those options are available. Switchboard feature, which we don't currently have. We can actually have a point of switchboard where one or actually about 10 of our units could serve as a switchboard at any given time. If we got into that kind of an operation where people weren't able to answer their phones directly, but they wanted it transferred, then that's a feature. And there's another integrated part of that. Music and advertisements on hold. That can be a double-edged sword. But I don't know what the director will recommend to me, but I'm guessing some light music of some kind. Voice app for cell phones. What does that mean? That means that your phone number is your phone number. You don't have to give out your cell phone number. An EH person or a home health person that's out in the field a lot can select at any moment and then unselect that 2 minutes later if they're too busy and they don't want to do that. But their desk phone will ring on their cell phone or whatever cell phone they designate it to ring on. This is extremely helpful in the EH division where our environmental inspectors are out in the field and may want to take calls because they're out and they're sitting in their truck and they're waiting for the excavator to get there, and they can get 4 or 5 of the people that are looking for information about their next upcoming appointment next week. So it just makes us more efficient, which is always what we're focused on. And then e-faxing and analog faxing capability, all of that will be integrated. We don't have to buy other phone lines and such. Enhanced call analytics. This thing will tell us how much time a phone is being used, what kind of calls are coming in, what's going out, what kind of data traffic is being used. All of that is available, and it's all available to us at any point on our own. Unlimited local and long distance calling, and this will show up a little bit later. We're actually going to save money on top of the money that we're going to save for a phone system. We'll save for long distance calling because there isn't any, essentially anywhere in North America. And that comes through this. So the 3 bidders all provided information. What we went with was Adnetics. Adnetics provided a very responsive bid that offered all of the items that the other 2 bidders offered. But in addition to that, their costs were significantly less. They provide a full service capability, and I'll show you just in a minute. They're locally based. Their customer service window is open much longer than the others. So not only were they cheaper, but they were better. in our view. So they're based in Post Falls. They're literally a few minutes away, and during this phase where we've asked them to provide equipment to us or to consult with us, they're here within an hour. They're a sister company to the company that was providing our fiber, Fat Beam. That's just a matter of disclosure. There isn't necessarily anything better or worse, but there is not now a conflict in terms of, well, you know, your provider is somebody else, and we don't know how their software works. That's been eliminated. 7 a.m. to 7 p.m. standard tech support times, which is great because it goes a little bit before and after our normal core hours when we tend to have problems. 24/7 monitoring and on-call support. So 24 hours a day, 7 days a week, we have their support just by calling. They will provide all the programming that we want. They'll do ticket by ticket changing of all of that, or they'll train us and our staff on how to do most of that on your own. The system is modifiable by basically the user if we wanted to allow users to have a variety of accesses. There's some reasons for not doing that, to have every user be able to program the phone system, but we're very comfortable with that. And they can also support, in addition, currently we have a different provider for security and for access control to the building that's all monitored. Their system is compatible with what we have. So we have another option if we want to choose something in the future. It would be available. Questions or comments?
Mr. Chairman?
Yes.
So Joe, obviously this has got to be HIPAA compliant as far as transferring medical information. Okay. And I like the idea that your different offices, whether it be the health division or the environmental health, can do your conferences, and you can communicate with them, train them, those kinds of things. That's great. And this company, I'm assuming, has an established track record. They come recommend.
Yes, we did their reference checks and due diligence and found not only we went beyond who they just suggested. All the people that they suggested were extremely pleased. The people that we knew that they'd done business with, on top of that, had equal or even more stellar things to say about the company. So we're very satisfied with that. And I'm sorry, I did not point out the detail. By doing all of this, we will save, I know this sounds unusual, but we will save actually $40,000 plus another $4,200. So about almost $45,000 a year. And we will propose at a future date, putting that into a board reserve account for IT and telecommunications. So kind of paying forward those savings. But we're very pleased that something that's so robust and capable is cheaper for us to use.
Do you have an ETIC?
Pardon me?
ETIC, estimated time of completion.
Right now, the hardware has been purchased. We're waiting on its delivery. I hesitate to give a hard date, but I'm going to say that I think by Christmas we'll be using new phones. So.
Dr. Banks? So Joe, who did the legwork to figure out all this and do the comparison and so on? Was that you or one of your?
Myself and Nick Metchikoff did the primary research on it, but then also Robert and Eric in IT provided a good deal of input, and also all the program managers for each of the different offices were consulted as to what their need sets were, and all of that was accommodated into it. So we did a pretty thorough process review of what we have and where we need to go.
Well, having had to do this before for myself, it really sucks having to do it.
Yes.
And so my hat's off to you guys for doing the legwork to figure this out.
It was a large project but fruitful, I think. So
good communications is critical to all of them.
Absolutely. And this will allow for some redundancy as well. Because if one system is down, we have a second provider, we'll be able to plug into that in the room and switch over. The equipment will not know the difference.
So your personnel, environmental, can use their laptops
Absolutely.
on location?
Absolutely. All interfaced. Mr. Chairman, that concludes my presentation.
Very fine, very fine. Thank you. My only question is how soon until this system will be out of date? Don't answer that. All right, let's move on here. So, Kim, how would you like to tell us what's coming up next and introduce our guest speaker for the day?
Thank you.
Okay, well, first of all, I will introduce myself real quick. My name is Kim Young, and I am a program manager over nutrition services and health promotion. So today, though, I get to introduce Kelsey Orlando. She is our project manager over our HRSA grant. That is a 3-year, $1 million grant that addresses the opioid crisis in our community. And the objectives through prevention, harm reduction, treatment, and recovery. She also has a health education specialist senior that helps her with these objectives that she oversees. She previously worked on our planning grant, and she was so successful, and her passion in this area led to this current grant, which we just entered the 2nd year. So today, Kelsey is going to talk about the partnership forum to help address substance misuse in our community. So with that, Kelsey.
Great. And can you all hear me okay?
Yes, ma'am.
Well, thank you, Kim, for that introduction. And thank you, Mr. Chairman and board. It's good to be with you all and share about the upcoming partnership between 2 of our designated rural Panhandle Health District clinics, Sandpoint and Kellogg, and Ideal Options, which is an addiction medicine and counseling company for opioid, stimulant, and alcohol use disorder. One of our Panhandle Health District strategic goals and priorities is to reduce the fatal and non-fatal rate of overdoses in our district. Response to this need continues as identified in our 2020 Emergency Department non-fatal opioid overdose presentations, where the rate nearly doubled from the prior year to 13.2 presentations per 10,000 visits. Improving access to treatment services is one approach that can support this objective by making these services available when a person is ready to seek help. Wait lists, provider availability, transportation, and stigma are all barriers for a person entering a treatment program. Treatment for substance use includes a variety of modalities and interventions, including medication, therapy, urine drug screens, group counseling, and peer support. Using an interdisciplinary approach helps personalize this care for a person to quickly establish stability. And the prescription medications for substance use disorder offset cravings, reduce the risk of overdose and misuse, and minimize the large swings of high and withdrawal a patient in active drug use experiences. Through an Idaho Department Health and Welfare Award, Ideal Option was granted funding to expand their services to 2 North Idaho locations. We've historically worked with Ideal Option in our community work groups, and after exploring locations for their satellite services, it was determined that Panhandle Health Clinics would be a viable and supportive environment due to the nature of our community-driven services, non-judgmental culture, and access to wraparound services to help someone thrive in their newfound recovery. Currently, we're drafting 10-month leases for our 2 buildings, which have an anticipated start date of November 1st, 2021. Ideal Option services will be available 1 day per week at each location with the goal to expand to 2 days a week. They will be hiring a medical assistant at each location, 1 care coordinator, and 1 peer recovery specialist. The provider visits are done via telemedicine, which allows them to have minimal waitlists for care. This project will generate income for Panhandle Health through monthly rental fees and is otherwise budget neutral. Furthermore, this project is supported by our HRSA funding, which has multiple deliverables to expand treatment services, coordinate care for people in recovery, and support interdisciplinary teams. I've been meeting weekly with their project staff since July to ensure a smooth launch and establish sustainability for this endeavor. We are all looking forward to the opportunity to better serve our community through ease of referral into treatment and reverse referrals into our clinic services by providing a medical home, family planning, and disease testing and prevention for their patients. And at this time, Mr. Chairman, I am happy to answer your questions.
Thank you. Questions, comments?
I have a question,
Okay,
Mr.
Dr.
Chairman.
Flanders. Yes.
Kelsey, just to clarify, could you clarify the renewability of this HRSA grant to provide longitudinal care over years ahead? What does that look like?
Mr. Chairman, may I answer?
Yes.
The renewability for the, can you clarify the lease or for the HRSA grant?
I guess both, because they both apply to ongoing longevity for the project, right?
Absolutely. So there's multiple sustainability measures in place for the HRSA grant to continue the work we are doing in opioid prevention, treatment, and recovery, with goals of seeking additional funding at the conclusion of that grant, which is August 31st of 2023, as well as the funding that is coming to Ideal Option. Thankfully, it is providing staffing and rental space, but because the services are billable, this will be a business endeavor for them as well, that they hope to find fee-for-service that can cover their costs as well. This pilot period is mostly to test the partnership to see if it's a benefit to both of us, both from our standpoint and theirs, to make sure we're meeting needs of the community, but also that from a staffing point and partnership, that it's a good fit for both.
Other questions? Did I see Glenn?
Thank you, Mr. Chairman. Kelsey, this program, I need clarification. Is it for individuals to come in to receive opioid treatment, addiction recovery? Is it a group setting or just one-on-one? Those are my questions.
Great. So to clarify, some of the services that Ideal Option offer includes medication for multiple substance use disorders, including opioids, stimulants, and alcohol. So that's through prescription medications. So their patients are people who have been identified with a substance use disorder. They see not only a medical assistant, they get regular drug or urine drug screens, and they also are prescribed medications that support the stability in their recovery. They also are encouraged to do therapy and counseling. Those happen outside of their office, but they are encouraged to find multiple avenues in their treatment to be successful. So they're seeing individual patients in this specific program of our partnership. However, they're using other individuals and partners in the community for those more behavioral health counseling elements.
Okay, thank you.
Other questions? Comments? Well, thank you. Thank you, Kim, for your part in this, and Kelsey, thank you for your very fine report. Appreciate it.
Thank you all.
All right. Okay, we're going to move on then and hear from Glenn if he has anything to share with us as our trustee. And following Glenn's report, we will take a quick break while Christine gets ready for her fiscal report. Glenn, you have the floor.
Thank you, Mr. Chairman. As far as updates, we have not had any executive council meetings since our last gosh, back in July sometime. So I have nothing to report at this time. We do have a meeting that we just are scheduling at this point. So hopefully I'll have something more to report at our next meeting. We'll see.
All right, I have asked Glenn at the next meeting to see if he can initiate a discussion among the other trustees to talk about director salaries. And we will have more to report on that at our next regular board meeting. Thank you, and we will be in recess for a few moments and give Christine a chance to get ready for her report on the fiscal conditions of the health district. We are in recess.
And then insurance. just says,
Okay.
"No, we're just not gonna pay."
We will come back to order.
Yeah. Is easy.
And
Recording in progress.
Christine, are you ready?
I am just about ready, Mr. Chairman.
All right.
Yes, it is. So as we usually do, we'll begin with our cash history worksheet. We ended August, which is the second month of our fiscal year. Our fiscal year runs from July 1st through June 30th. We're in fiscal year 22. We ended the month with $4,700,000. Before board committed funds and program restricted funds, it gives us 3.76 months in reserves. If we take out our board committed funds of $513,700 and program restricted funds of $223,700, it gives us 3.17 months in reserves. I'd like to remind everyone, board committed funds are funds that the boards have committed for building maintenance, the 27th pay period, IT funds. Program restricted funds are those funds where we have already received the cash, but those funds are designated for a specific use. Moving on to our budget to actual. Oops, I didn't put share. No, we're not. Make sure that's what.
Sure.
Let's just make sure. No, which, yeah, this one. So our budget to actual, our total revenue for the 2 months, $2,200,000. We are under budget by $454,000. The detail of that, licenses, environmental licenses, we were over budget by $34,000. Home health services, we were under budget by $69,000. We have the referrals, but currently it's a staffing shortage issue, and that is apparently happening throughout the community and other home health agencies. Clinical services, we were under budget by $27,800. Number of factors play into that. Several would be patients are not making the appointments, similar to what happened during the last COVID surge. And also time is being spent in the clinics related to COVID activities, vaccines, and grants and contracts. We were under budget, and the primary reason for that is a delay in calculating the indirect rate, which is calculated every year. That's where we allocate the administrative cost out to the programs. It was a unique year because of the effect COVID had on it. The other reason, is fiscal staff vacations, and we also lost a fiscal staff member.
We just recently, by the end of September, we have billed out our contracts for both July and August. So we should see that come back around for our next board meeting. We are currently under budget in expenditures by $213,000. We are over budget in capital by $657,000. Now, you'll recall in our June board meeting, we elected to make a large principal payment on the Hayden facility, and we paid $680,000. That was not included in this budget. And of course, this spring, we'll be looking at budget revisions. But that large payment accounts for the additional principal payment on Hayden and also the payoff of the Sandpoint facility. Trustee benefits were under budget by $12,400. Total expenditures over budget by $241,000. Overall, when we account for revenues and expenditures, we're in a deficit by $695,000. We adjust for our change in accounts receivable to bring us back to a cash basis. We take that change, add it to our beginning of the year cash balance, and it brings us back to our ending balance of $4,700,000. Mr. Chairman, any questions?
Any comments or questions? Did you want a drum roll when you announced the payoff of the Sandpoint building?
We'll have the drum roll when we pay off the Hayden building.
According to my calculations, this building is scheduled roughly to be paid off in what, 2.5 years?
2024, May, yes. Yes.
Good.
So if there are no further questions, this concludes my report.
Thank you.
Thank you.
Thank you. A good positive report indeed. All right. We have a director, and he's going to give us a report at this time.
Thank you, Mr. Chairman. Just a couple of items I wanted to touch on. First of all, a COVID-19 update. We continue to vaccinate, or I should say, we continue to provide opportunities for people to be vaccinated, as well as many of our partners throughout the 5 northern counties. It's not just us. We meet weekly with what we call our North Idaho Vaccination Distribution Team, and we get great assistance from those partners. One of those is Northwest Specialty Hospital. Thank you, Dr. Jameson. And what we're seeing here in North Idaho, we're seeing about a 1% to 2% increase in fully vaccinated each week. So we're seeing an increase happening, which we're happy to see. Just to give you a couple of numbers here, in terms of fully vaccinated folks within the 5 counties, we're seeing 47% of our population and 51% that have received at least 1 dose of the vaccine. And so that continues to increase for us throughout the 5 counties. Nationally, there is some indication that there has been a peak that's been established and cases are dropping. However, in Idaho and 2 of our neighboring states, Wyoming and in Montana, that is not the case. We continue to rise. That's been pretty typical of Idaho, where we're kind of behind the curve in our rise or drop. So we're following that. To give you some numbers to support that, in Idaho, I got these numbers 2 days ago, that there were in the entire state, there was 1,117 cases per day in the past 30 days. In the past 14 days, that number is 1,212. So still on the rise. One area that is rising dramatically, as I mentioned earlier, is with school-age children, and we discussed that earlier. We have Heritage Health and Northwest Specialty Hospital are providing monoclonal therapy for patients that are quite sick and providing treatment for them. And we're finding that to be a very successful service so far. Very much appreciate their service. In fact, the governor was here on Wednesday to visit Heritage Health yesterday, and appreciate their great efforts in that regard. Of course, we continue to worry a lot about hospital capacity. Today, we got a report that Kootenai Health set a record, unfortunately, of 120 inpatients with COVID-19, with over 41 in their ICU. And so that is an area where we get involved in to try to help what we call hospital decompression, working with our partners to see what we can do. But that is a tough task, to say the least. We also are involved in providing opportunities for those that are wishing to have a third dose of vaccination. Again, these are those right now. It's essentially those that have some sort of significant immunocompromised situation. And so we're providing that opportunity as well. We don't have any indication yet of what would be the booster coming for the rest of the population, but more information will be coming on that as well. So just can't say enough about our amazing staff and volunteers that stay in the trenches every day and provide this opportunity. To say it's a challenge is a significant understatement, and I have great respect for them as they continue to stay in the fight. Wanted to update a little bit on House Bill 316 and where we are. So a little bit of an update on that is going back a little bit. This House Bill 316 will be enacted on March 1st of next year. Going back a little bit, if you recall, the state activated Medicaid expansion. That is a cost to the state to do that. So they looked for ways to save money on that. And they immediately looked at the counties to incur some of that, in the sense that with Medicaid expansion, now that everyone will have the opportunity to have health insurance, there will no longer be a need of the indigent fund that each county has. As you recall, the indigent fund was set up for those that have no insurance and financially qualify. And it is a place where patients without insurance that financially qualify could get their bills paid. And that's a significant cost to the counties. So the state looked at that and said, okay, we are going to absorb the cost of Medicaid expansion, and you counties will save money. That's most of the counties, not all of our counties. And with that savings, we're going to ask you to fund more of the responsibility for health districts. So again, just a little thought on that. Right now, roughly 78% of the funds that come to a health district comes through grants and fees, leaving 11% for the state and 11% for the counties. So the state looked at that and said, with your savings, instead of the counties paying 11%, we're going to ask you to pay 22%. And they feel that that savings is going to be compensated by the county saving in the indigent fund. So that was one of the purposes of House Bill 316. And that change in financing for the health district begins on March 1st. The other part of House Bill 316 is to give more control to the health districts, to have less dependence upon the state. And primarily, there's several areas, but primarily with their fiscal and payroll and HR services. So on that vein, I am and other district directors are beginning regular meetings with the State Controller's Office, the Department of Human Resources, to determine how that transition will take place. I'm very happy that the state has come out, and as Brandon Wolf, the state controller, said, we would never kick the health districts out of the pool, meaning we will still have access to their systems. And one of the caveats is they're switching to a new systems for HR and fiscal, which is called Luma. So that's an interesting part that's also happening simultaneously with this change. But they will allow us to continue to use their systems and then have the control with HR. Now, when I talk about that control of HR, when we have to go through hiring a new employee or to look at raising salaries, we go through a very laborious process to get approvals from the state. And there are some good things about that in terms of keeping things kind of similar throughout the state. But on the other hand, it very much delays our ability to make changes as they depend on the market. And so we're looking forward to that change, but with some hesitancy on how all these transition steps will take place. So I have gone to the district directors as we have this meetings with the state controller's office and the Department of Human Resources. And I asked them to allow Christine and Michelle, Fiscal and HR, to join me on all of those meetings. And they have allowed me to do that. So the three of us, and I'm very happy for their support and knowledge and expertise, will be working through this transition. So certainly more to come on all of this. And I just want you to know we're definitely at the table. We're offering many suggestions, and we will continue to do so. So I know that's a lot of information on this House Bill 316. Any questions before I move on?
Well, yes.
Mr. Chairman, Don, are you keeping the county commissioners in the loop as far as these issues and what you are recommending? Or are they out of the loop? Is this, as far as awareness is my question. Are they aware of these issues with House Bill 316? And are we communicating our concerns as well to our legislators from 5 northern counties?
Mr. Chairman, thank you, Mr. Bailey. I really appreciate that question. When our previous director, Waylon, and I went and did our budget presentations to all the counties, we did give a fairly detailed description of House Bill 316 at that time.
The issues, concerns were.
But those issues and concerns continue to come up. I believe that's the only time that the health district has spoken to county commissioners regarding this. Now, I believe they're getting information as well, but I would welcome the opportunity to speak with any of our commissioners to make
updates or something like
Yes,
that,
sir.
I think would be something beneficial, and they'll feel like they're more participatory in it, and they can give you their feedback as well. Then you would be able to, the next meeting, say, hey, we have these concerns from our county commissioners, or, something like that. So they feel like that they are being represented, because the health districts and the counties are now like this.
Yes, sir.
So,
Yes, sir.
I would like to tie on to that. I'm glad you mentioned that, because I would direct over here to Tim. Do you really think that this is going to pan out as lovely as the legislators think it will, as far as this transferring of the indigent responsibility and that money coming to the health district?
Like Don said, for some counties it'll be fine. Other counties it will not work out that well. They're going to have to find schemes.
So, see, and that's not going to go down easy. If all of a sudden the monies to bump this from 11% to 22%, that other 11% is more than what you may have spent with your indigent issues. And I imagine that, Tim, you're sensitive to that, and I think that question gets Mike's attention too. Mike, do you have a comment?
Yes, Mr. Chairman, I want to follow up and first off, compliment Don Duffy and Laura Whalen, when they did come, they did a very good job of walking us through what was in front of us. We were participating directly through the Idaho Association of Counties and being informed of all the twists and turns that led to House Bill 316. In the last item, I again want to thank folks at Christine specifically, because I was able to contact her directly, and it helped us in establishing this upcoming year's fiscal budget and what those expenses were going to be, what that 22% was going to be. My last comment on it is we're not exactly sure how the balance sheet will come out with respect to the indigent savings. Estimates make us come basically down even on the thing. So we were very well informed of the changes and what was in front of us, but B, we're going to just have to stay tuned to see what the final balance sheet looks like.
All right, thank you. But it still leaves a question in your mind, doesn't it?
Well, obviously, it's an ongoing negotiations, and I think it'd be helpful to keep the county commissioners updated after the meetings and what Panhandle Health District's position is in representing this. So
I would agree with that.
yeah, they would support you a whole lot, I'm sure.
Yes, Mr. Chairman, I completely agree with that. I would welcome the opportunity, and I will do so. I will set up regular meetings with our county commissioners, providing they're willing, and I will give them regular updates. I might just add, I understand there's going to be some ups and downs on this, but there also is something positive about bringing this back to more local responsibility. And I appreciate the opportunity that they might address our fiscal responsibility going forward. I think that's appropriate for our county commissioners, and I look forward to having those discussions with them. The last item that I have is regarding our, actually I have a couple of more items, two that aren't on your agenda at this point. My replacement as division administrator. So I had a discussion with our chairman about this, what we might want to go in the future. And I wanted just to share a few statistics with you and then offer you what my solution is. In my current role, I had 86 individuals that were under my responsibility. Our environmental, which is also very busy, they have 45. And we have not changed the management structure for as long as I can remember here at Panhandle Health District. So what we have decided to do is to replace my position with 2 division administrators. And one would be over health services administrator, and another would be over clinical services administrator. And that still breaks that down to 53 employees under this clinical services administrator and 33 over our health services administrator. For comparison purposes, if you look to the other counties and how they're doing this, so we have the largest budget of all 7 counties here at PHD1. And what I'm suggesting is that we go, from 2 division administrators to 3. Other counties, Health District 2, which has a budget that's less than half of ours, they have 4. District 4, who are less than ours, they have 3. District 5 has 4. District 4 has 2. District 5 has 2. And District 6 has 4. And District 7 has 5. So at 3, we're going to still be less than all of the other districts with the exception of District 5, and still have a highest budget and staff to manage. And I'm very much like the idea of these 2 division administrators being more proactive than what we've been in the past, and really having an easier ability to manage the over 40 different programs that we have under those services. So we have begun that search. The search will close on the 14th of next month. And we're starting to collect resumes for those 2 division administrators. Now, there's a bit of a caveat with all of that, and who's going to apply. Finding qualified staff in our market is very, very difficult and challenging. And so we'll see how that goes as we continue that search for those 2 division administrators. So I wanted to give you an update on that. Any questions that I can entertain on that, Mr. Chairman?
Mr. Chairman, Don, so I guess you've already looked at how you would break down between those division administrators, what their qualification levels, job description, all that good stuff is, I'm sure. And you're using HR to a huge extent, hopefully, so.
Yes, Mr. Bailey, we are. And the clinical services will just be that. It'll be clinical. So I'm very hopeful that we can get a well-qualified RN to accept that position. I very much would like to have an RN on our executive team. Director Whalen was an RN before. I think it's critical that we have an RN that continues to be on our executive team. And then health services division, lots of programs. One of the programs that's growing dramatically, as you heard earlier, is opioids, and that needs good management. So we'll be tracking that as well.
Thank you.
The other item I have, one thing I'm sorry I failed to put on our agenda is November the 18th is our next Board of Health meeting. And typically that's been our legislative update meeting. And Mr. Chairman, I wanted to reach out to the board to see if they are willing to and wish to invite legislators to that meeting as we have done in the past.
Would that also include county commissioners?
Yes, sir.
In the big room.
Definitely in the big room.
We do not have what you could really classify as a district in the city. Let's toss that in.
Appreciate that perspective. Thank you, Mr. Chairman.
So we have a lovely yard.
I don't think the weather will be great on November the 18th.
My position on having a legislative update, I think it's extremely important that we have a legislative update day on our calendar, even if no one comes, which won't be the case. We would have 2 or 3. But sometimes it has not been highly attended, but it's still important that we have this date. So at least we could say we offered you the opportunity to come and ask questions.
Mr. Chairman,
Yes.
I'd like to also piggyback on that with what Glenn had said. I think it's a good opportunity to make sure the invitation is out in advance and well known by the commissioners for them to attend also.
Thank you.
Mr. Chairman?
Yes.
Don, just a suggestion that this House Bill, 316, and the issues of concern might be something that could be briefed to them as to what you and the county commissioners' concerns are with it. And you can kind of discuss it with the legislators. And maybe that would influence them to come to the meeting prepared to discuss it, because I'm sure they have concerns as well, but they are our elected representatives. And they need to be communicating with the county commissioners and with you as the director of the health district on your concerns of these issues, so that they can know what your position and the county commissioner's position or thoughts are. I think that would be helpful.
Mr. Chair and Mr. Bailey, that is an excellent question. And I think we ought to lead, that ought to be the lead point
The
in our,
focus.
in our invitation. Absolutely.
Okay.
All right?
I have one more item,
Yes.
Mr. Chairman. I apologize.
Go
The
ahead.
most important item on our agenda today is our esteemed chairman. It was his birthday. And I have a card that has been signed by many of our health district employees. And I, for one, have tremendous respect for our chairman. I'm so grateful for his continued effort. I was talking to him earlier about, and I really had to prod him a bit about the level of service he's provided so many for so many years. He is one of the best examples I know of a public servant. So Marlo, happy birthday.
Yes, thank you.
And there's cupcakes in the, go over here on the table.
The thing I keep saying to you people, every time I have a birthday, in between my birthdays, every one of you has also had a birthday, but we don't hear about it.
Thank goodness.
We're not as distinguished.
No, but I do appreciate your kind words and the support I receive. I am devoted to this organization, and it's been a great experience. This health district with Dr. McLandra's years and my years and Alan Banks' years, there is no health district that comes close to us as far as having board members with longevity. And if you added up just the three of us, our total years, I haven't done that, but it would be
It's best that we don't.
it's best that we don't. Because remember, Dr. McLandris came on this board in 1986. And I came on this board in 1993, and Alan came on this board in 1997. And with that, my dear friends, the next meeting, November 18, and if there's no other business to come before this board at this time, we are adjourned.
Okay.